Hello friends, I am Dr. Professor Rahul Kawatra, and today's video is about the history taking of an ear case. So I am going to take you through the list of important complaints that we must ask our patients, especially who have got a ear problem. And you are going to find a few set of useful tips and important key questions. So listen through the entire video, and I hope it's going to be helpful for those students who are preparing for their MBBS practical exam. Thank you. So we start with the history taking of a patient who has got a ear problem. The very first thing which we start with, as with other history, is the patient particulars. That is the name, the age, the sex, the occupation, the address, and whether the patient is from a rural background or an urban background. Okay, so the importance of all the patient particulars I've already discussed in my history taking of a nose case. So you can go through that video, and certain in brief that I can tell you is that there are certain problems which has a sexual predilection, and even the occupational hazards where the noise exposure is more, the patient is likely to have diminution of hearing, and patients of rural background tend to be more commonly affected with chronic suppurative otitis media in comparison to the patients of urban background. And coastal areas, the problem of automycosis is even more, and even the weather can induce problems like automycosis and otitis externa. So these are the certain important things which we have to probe in depending upon the problem that the patient has. So it is important in that light to be particularly dwelling into this issue of the patient particulars. So another word is that we have always heard from everyone that, and in the medicine it is also taught that the history is to be taken in the words of the patient. So in that regard, I would like to say that the patient should be encouraged to talk freely and tell his or her own problem in his or her own words in the first initial minutes. But then, if you find that the patient is deviating from the issue, then thereafter we must interject with certain specific questions to get a more clearer, a coherent, and a more concise history recording. Because the idea is that we, when we sit for our practical exam, we get approximately 40 to 45 minutes to prepare our case. So it is important at that point of time that we don't overspend time in taking the history. And irrelevant history, as I say, should be eliminated, because at the end of the day, when you are presenting your case, any statement that is not fitting into the diagnosis taken in the history will create problem for you. So my word of advice is, take the relevant history from the patient, and any statements from the patient which appears to be not fitting into the diagnosis should be eliminated. For example, that if the patient complains of itching in the ear, and when you have a look inside the ear, you do not find any problem with the ear. So now either you have to give the answer to what are the various causes of itching inside the ear, or you better eliminate that statement, right? So that is just a small example. So after this, the most important thing is that you have to take the chief complaints in a chronological order based on the duration, and try to be as short as possible with only 2 or 3 maximum complaints which the patient is mainly concerned about, and then you move on to the history of the present illness. Now this you have to, it is basically the elaboration of the chief complaints, so nothing new about it. And also if any other problem if patient is having, and for every specific complaint, each complaint that you ask, you must focus on the onset the of the problem. That is, you specifically ask whether the symptom started abruptly, or was it a gradual onset, or was it following an illness or any other incident. So the onset of the complaint has to be asked. There are certain problems like sudden sensory neural hearing loss. There will be hearing loss after a sudden noise exposure. So that is an abrupt problem. And chronic suppurative otitis media are generally problems in hearing develop very gradually. That's just to give an example. Okay, then next you ask about the course or progression of the symptoms, that whether the symptoms have gone for days or whether it is for months, and or whether it is for years, and are the symptoms intermittent or whether they are recurrent or they are continuous. So the course and the progression of the symptom is also must be asked. Then the duration, what is the total time since the patient is having this complaint. So this creates a little bit of confusion, especially when the patient is unable to tell you. So you must ask specifically that, supposing if the patient is having a hearing problem, you must ask. Initially the patient might tell you that the hearing problem is for few days, but then if you ask specifically the total time period since the patient is having this problem, then he might tell you that gradually he has been having this problem for past 6 months and it is slowly increased. Okay, so this is what you have to be clear about, the total duration, because that sets the can give you a better idea what exactly is the problem you are dealing with. Then the aggravating and relieving factors, what seems to influence the symptoms. Are there any episodes of respiratory tract infections or any other issues that tend to increase the problem? Or next is the unilateral or whether it is bilateral, the laterality of the problem, especially in ear cases or in nose cases, you have to be clear whether the problem is in one ear or in both the ears. So this is what is important, even in for nose, and a treatment history and its effect. All these complaints like onset, course, duration, aggravating, relieving factors, the laterality and the treatment history has to be, the present complaint has to be elaborated on that front. And now I'd come on to certain specific complaints which are pertaining to the ear, because this was initially just the general part that I was discussing. So we start with the most important complaint that a patient of ear problem will come to you is the ear discharge, and you specifically ask for the smell, whether it is foul smelling or whether it is non-foul smelling. So smell is a very important complaint in ear discharge. So you have to be very clear whether it is foul smelling or non-foul smelling. But the word foul smelling is specifically to be used for unsafe CSOM, especially at the level of undergraduate students. So you have to be, whenever you are saying that the smell of the ear discharge is foul smelling, be sure that your diagnosis is moving towards unsafe CSOM. Okay, so these are the key point that which in history which will favor your diagnosis. I hope I am clear about it. And the reason why we have this fishy or rotten egg smell that is there in foul smelling, you can be asked this question, why do we get foul smell? So the answer is because of the enzymatic activity and the growth of the saprophytic bacteria, and another condition which is called as osteitis, which leads to the bone erosion. So, these are the two reasons which actually lead to the foul smell odor. So there is growth of the saprophytic bacteria and anaerobic bacteria like Peptostreptococcus. All these things are actually leading to the foul smell. And then there is always this granulation tissue or the cholesteatoma which is present, which leads to this bony erosion and the enzymatic activity of the cholesteatoma. And if the smell of the discharge is non-foul smelling, then we mean that it is a safe CSOM or a case of acute suppurative otitis media, right? Then another important complaint in about the ear discharge we have to dwell into is the nature of the ear discharge or the consistency. So you have to specifically ask your patient. These are certain leading questions that I was trying to tell you that patient might not be able to tell you in the beginning. So you have to interject in the history and ask whether the discharge was mucoidal. By mucoidal, we mean that whether you have to ask whether there was it is sticky in nature or not, right? Or it is very thin, thin or serous. So that is non-string forming, and whether the discharge is mucopurulent or purulent. Okay, so mucopurulent is something where there is mucoidal nature as well as the purulence there, and in purulent discharge is invariably present only in unsafe CSOM. Okay, and the causes that can be there which can lead to purulent discharge are furunculosis and malignant otitis externa, but generally you can be asked as a viva, where else can you get purulent discharge? So you can tell in furunculosis and malignant otitis externa, but by default the case that you get is a case of safe CSOM or unsafe CSOM. So you have to be clear that mucopurulent discharge or mucoidal discharge will be present in safe, and purulent word if you are using, then we mean that we are talking about unsafe CSOM, because the question will be framed in that manner. What are the points that favor your diagnosis? So purulence favors the diagnosis of unsafe CSOM. And if the discharge is watery, it can be present in CSF otorrhea. Another important question that you are going to ask from the patient regarding the discharge is the color of the discharge. So the growth of Pseudomonas infection can lead to a greenish discharge, but normally the discharge which is mucopurulent or purulent can be creamish yellow. Okay, then you can have another question that you ask is whether the discharge was blood stained or not. All right, so or whether it was frank blood. In certain cases you can even of trauma or hemangioma or polyp, granulating polyp in the ear which bursts, that can cause frank blood. But if the patient says there was little pus and there was a tinge of blood in it, then the common reason is the granulation tissue in the middle ear. So blood stained discharge will again indicate towards an unsafe CSOM, that is an atticoantral disease, or in certain rare cases malignancy of the ear also. If you are asked a question where else can you get blood stained discharge, then you can say it is present in malignancy of the middle ear. Okay, or maybe simple trauma of the external auditory canal. Okay, so there are little bit questions that the examiner keeps asking you about every point that you are saying. That is why I say that the relevant history has to be told. Otherwise, whatever statement you are saying, will the examiner will ask, why do you say this? And it will be very difficult for you to answer why if you don't have a relevant finding related to it, or if it is not fitting into your diagnosis. So you might spoil your long case or your short case, right? Then you ask about the quantity of discharge. So whenever you're using the word profuse discharge, which means that the discharge practically comes out and stains the pillow, that's how you come to know whether it is profuse or not. Then you are talking about the safe CSOM or the tubotympanic type of CSOM, right? And if the discharge is scanty, then the patient will say that only the tip of the earbud is stained with the discharge, or practically there is just smell, or discharge is barely visible. So that is indicating of unsafe CSOM. So these are all points favoring a particular diagnosis, whether it is safe CSOM or unsafe CSOM, because these are the common cases that you get as an undergraduate practical exam of MBBS. Then, whether the discharge was active, inactive, or in quiescent stage, the question that you ask is whether the discharge is present or not, or if the discharge is not there, then when did it stop? If it has stopped just about a few days back, then it is probably the quiescent stage of CSOM, and if the discharge has been not there for more than 6 weeks, then it is the inactive stage of the CSOM. And if it is still discharging, which you can even see in your examination finding, then the discharge is said to be active. So you can go back to your history after doing an examination. So there's no hard and fast rule that once you have taken the history, you cannot change it. So in fact, it is always prudent that once you have taken a history and you've done a quick examination and you've come to a diagnosis, you go back to your history and revise those points which are favoring your examination findings, and which are points in favor of your diagnosis, and try to eliminate all those irrelevant statements recorded in the words of the patient which are going against your diagnosis. So it is important to prune your history once you have done your examination and reached your diagnosis. Okay, so this line you should always remember, that you have to prune your history once you've done your examination. Then another point is that you have to tell whether it is continuous or intermittent discharge. Where if it is continuous discharge, you are saying that the discharge was continuous, then it means that you are talking about unsafe CSOM. So I'm repeatedly saying the same things just so that the points are emphasized properly. And if you're saying that the discharge was intermittent, then it means we are talking about safe or tubotympanic type. Then relation to upper respiratory tract infection, in safe CSOM, it aggravates with upper respiratory tract infection and stops when patient is not having any throat problem or upper respiratory catarrh. And in eticoenteral type, there will be no change at all, or maybe sometimes it can increase, but definitely no change. So it is not affected by the episodes of cold, cough, and sore throat. And then whether the patient is relieved with medication or not. And another important point which can tell you about the eustachian tube patency while you are recording the history is that if the patient has taken any ear drops, so does those ear drops give any taste, or is there any feeling of any bitter taste in the throat? So this specific point you can ask your patient, which can indicate whether the eustachian tube was patent or not. So this was about the ear discharge. Another important complaint that you ask your patient is the history of deafness or the diminution of hearing. So aside from the points of onset, course, duration, the laterality which I've already talked of, it is specific to ask about the onset, and then whether it is unilateral or bilateral, and important to know whether the onset was gradual or sudden. Conditions like CSOM, the wax impaction or noise induced hearing loss, ototoxicity and otosclerosis. These are problems where we have a gradual diminution of hearing. So out of it, the most important one is your CSOM. Then in unsafe CSOM, you may even, patient may not even be able to know how slow. If it is very, very slow or very, very gradual diminution of hearing, it is labeled as insidious type of onset. Okay. And sudden, then can be viral infections or fractures of the temporal bone or sudden sensory neural hearing loss because of sudden exposure to noise and then acoustic trauma, or maybe a rare condition which is called as a perilimb fistula, which is just for the viva question point of view, where you can be asked what are the common causes of sudden hearing loss. Okay, then the course is progressive, whether it is stationary, whether it is fluctuant. So few examples: in progressive, very commonly seen in sensory neural hearing loss, and generally it is a long standing disease. The course of diminution of hearing is invariably stationary most of the times in cases of safe CSM, specifically in situations where the ear has not been discharging for a very long period of time. Okay, and a fluctuant type of hearing loss, another viva question, is seen in secretory otitis media or in Meniere's disease. Then we can, by conversing with the patient, also we can know whether the degree of hearing loss is mild or whether it is moderate or it is severe. Because if in soft conversation the patient is unable to hear, then it means that the loss is mild. But if the patient is unable to catch all your statements and questions in a normal conversation, then the loss can be moderate. Or if you need to speak loudly with the patient, you know that the loss is of severe type, and then you can confirm it in your examination by doing a tuning fork test. So you go back, do the examination, and come back to your history again and tell about the degree of loss, that the loss appears to be moderate in nature or it can be mild or severe. So you actually come back, pruned your history, because this statement may not have been given by the patient or may or not have been recorded by you in the initial history recording. So then the relation to the discharge, whether the hearing improves with the discharge. So this is very commonly seen in ossicular necrosis, because the discharge bridges the gap between the plate area and the tympanic membrane area, which is not there. So that gap in the middle ear is bridged by the discharge, so the patient tends to have a better hearing. But once the discharge dries up and there is ossicular necrosis, so there is a discontinuity which leads to the diminution of discharge. And in routinely, if there is worsening of the disease, then the hearing deteriorates. So this is what it is. And you can always ask about the relation to the noisy environment, what kind of environment the patient is coming from. So there are the cases of sensory neural hearing losses where if the patient is in a noisy environment, living in a metro or maybe nearby a railway line or something where there is too much, or maybe working in such a factory where there is loud sounds, can be having early hearing loss problems. Then condition like otosclerosis, there is a condition called as paracusis Wilsai, where the patient tends to have a better hearing in noisy surrounding. So this is a paradoxical event. Important question to be asked in the viva: what is paracusis Wilsai and where is it present? Then any distortion of sound, which is that the same sound is perceived in two different ways between the two ears in terms of sensitivity, in terms of intensity and the tone. Okay, so that is called as diplocusis, which is seen in Meniere's disease. So if the patient is having active Meniere's disease, there will be a distortion of sound in the two ears, two different ears. Okay. So this is again an important viva question which can be asked when you are presenting your case. Then if there is any alteration of sound during the work, and a patient is having an episode of vertigo, this again points towards Meniere's disease. So in a patient of Meniere's disease will have an increase in the deafness, and then it generally normalizes after an attack. So this is again an viva question only when you are presenting a case of CSOM. Normally you don't get cases of Meniere's disease are not given to undergraduates, but it can be, it's an important viva question. All right. Next we come to another complaint which is called as earache or otalgia. So whenever you are saying in history, you will not say that the patient had otalgia. So it's a technical word. You always say that the patient had earache, and you have to talk whether it is, what is the onset again, whether it is acute or sudden, commonly seen in trauma, acute otitis externa or acute otitis media, and gradual or insidious seen in CSOM with complications, because normal CSOM is a painless condition. So if a patient of CSOM gives a history of gradually increasing pain in the ear, so then probably we are moving towards some impending complications, specifically like mastocytitis, or if there is an episode of secondary infection leading to the inflammation of the middle ear and the surrounding structures like the external auditory canal, leading to otitis externa and then leading to pain. So otherwise, normal history, if the patient says that there is some pain, but when you look in the examination and you find no evidence of any inflammation or any sign of complications, so it is better to come back to the history and eliminate that complaint of earache. So that's what I'm trying to tell you. You have to prune your history. Time and again I'm telling you. Okay, it's very important to present your history as well as your examination findings which are supporting your diagnosis, rather than presenting histories which are giving vague statements and they are confusing your diagnosis. Okay, and you don't have any presentation in the examination to support that history. All right. So the nature of pain, whether it is sharp, throbbing, can be seen in acute otitis media or acute otitis externa. Then dull aching pain is invariably seen in serous otitis media or even in furunculosis. Important point as far as earache or otalgia is the site of pain. So this you must specifically ask the patient. If the patient says that I have pain, then you must ask where exactly it is. And even while doing the examination, you can find if the tragus sign is positive and you find a furunculosis, then you are confident to tell that the come back to the history and add that the pain is there in front of the ear. Or if it is a patient of acute CSOM with acute exacerbation, then the pain, you can tell it is deep inside in the ear. And if you find mastocytitis on your examination findings, then you can say that the pain was localized by the patient to be behind the ear. And in cases of eustachian tube salpingitis or parotid gland diseases, then the pain is generally confined to the lower part of the ear or below the ear, right? Then as far as otalgia is concerned, you have to be clear that whether it is the problem because of the local cause or whether it is a referred otalgia. And the common 5 T's that we talk of, it's a viva question. You are invariably asked what are the common causes of referred otalgia. So remember these 5 T's that are the source of referred otalgia, that is the tongue, the teeth, the tonsil, the temporomandibular joint, and the throat. And the nerve supply which causes it is the 5th, 7th, 9th, 10th, 11th, and C1 and C2 cranial nerves. Okay, so even the spondylitis is also one of the common causes of rhaphodotalgia. Okay, and if the patient is complaining of pain while chewing, then more likely that the problem is in the external auditory canal, which can be because of furunculosis or diffuse otitis externa. So here we are completing the main complaints of ear discharge, the diminution of hearing, and the pain in the ear. So always try to use the language. Don't use don't use deafness. Sometimes you can, but prefer using diminution of hearing, ear discharge, and earache, not otalgia. So these are the when you are presenting your history. Then another important complaint is of tinnitus, which can you have to differentiate what kind of tinnitus it is, whether it is subjective or objective, and the causes of subjective tinnitus in the external ear are wax and dry crust. In the middle ear, it's commonly acute suppurative otitis media, secretory otitis media, or active CSOM. So you can have a subjective tinnitus present in active CSOM. And in inner ear, the common causes are Meniere's disease, labyrinthitis, and acute acoustic neuroma. And the systemic causes are anemia and hypertension. And a viva question is objective tinnitus is commonly seen in AV malformations, palatal myoclonus, and a patulous eustachian tube. Okay, so it's an important viva question that is asked is what are the common causes of objective tinnitus? The answer is AV malformation, palatal myoclonus, and patulous eustachian tube. Then you have to ask about the laterality. So invariably unilateral tinnitus is present in acoustic neuroma, and bilateral tinnitus is seen in cochlear type of otosclerosis. Vertigo, if it is associated with tinnitus, is commonly seen in Meniere's disease, and it can be a warning signal. So tinnitus can be a warning signal in a case of Meniere's disease of about an attack of vertigo. So it can act as a warning signal that the patient is going to have vertigo. So that is what the history will be given by the patient of Meniere's disease, that there are sounds which are heard by the patient before he gets an episode of vertigo. So then we know that the diagnosis is more towards Meniere's disease. Okay. Then if tinnitus is associated with deafness, and especially the triad of tinnitus, vertigo, and deafness is seen in Meniere's disease. And tinnitus can also be present in cochlear type of otosclerosis, which I've already told you. So these are the common specific questions and complaints that you would ask about from a patient who's got. But as far as an undergraduate is concerned, the problems of tinnitus invariably is indicating towards an active CS1, or maybe some systemic issues which can be there, or if the patient is having some other problem like Meniere's disease. So you have to be clear in that when you are presenting your history in the practical exam. Then another important complaint that is there is about vertigo. So vertigo is what? It's basically a false sense of rotation that the patient gets even when the surroundings are static. Okay, so you have to know if the patient has a problem of vertigo, you must ask about the intensity of vertigo and the duration, or since how long the patient has been having vertigo. But from undergraduate point of view, the association of vertigo with ear discharge is invariably uh, suggesting an impending complication of CSOM, which is labyrinthitis. So let us be very clear that when we get a patient of CSOM and the patient is complaining of vertigo, then probably we are talking about an unsafe CSOM, and the common reason for getting vertigo is labyrinthitis, acute labyrinthitis. Then vertigo, if present in a particular position, irrespective of the problem, will indicate towards benign paroxysmal positional vertigo. So positional vertigo, as the name suggests, benign paroxysmal positional vertigo. So vertigo which is related to the position. So patient will say that by changing head positions, the patient gets dizziness. And if vertigo is associated with tinnitus and deafness, as we discussed, indicates towards Meniere's disease. And another important thing to differentiate between Meniere's disease and vestibular neuronitis is that this vertigo will not be associated with deafness in cases of vestibular neuronitis. So that is the reason why we emphasize that it is very important to take a history to come to a diagnosis in a patient of vertigo, because a patient of vertigo may not have any physical signs except for nystagmus, and all you have with you to reach a diagnosis is your history. So don't underestimate the power of history. Okay, so that's what I say, that uh, the history and examination both are equally important when you have to reach your diagnosis. So sometimes, and history gives you a fair information what all findings you might be getting in your examination to support your diagnosis. All right. So other reasons, that if the vertigo is associated with headache, then it can be a migrainous vertigo, or if it is the cervical movements of the neck, then it is cervicogenic vertigo. So this is, and another important complaint that we sometimes have is the excessive loudness of one's own voice, which we call as autophony. This is again a specific complaint which you ask the patient if your diagnosis comes out to be secretory otitis media or patulous eustachian tube, because this may not be told in a direct history. So this is a history which you have to take out from the patient. Okay, then other complaints like fever and headache, which can be, fever can be an acute mastocytitis, which is again a complication of acute otitis media, or maybe chronic otitis media even. And headache will indicate, in a case of CSOM, intracranial complications like brain abscess or a lateral sinus thrombophlebitis. Okay, so if a patient complains of headache and you do an examination, you find that the patient has safe CSOM, so please go back to your history and remove that problem of headache, because that will become a big headache for you to explain why the patient is having headache when you have a diagnosis of safe CSOM. So I hope you understand. I'm repeating myself, but it is important. So remember the basic, these are the small mistakes that you undergraduate people do, that you don't look back into your history after doing an examination and bringing your diagnosis, and you take it very lightly and simply say that the patient said that he had headache. But you have to evaluate why he had headache, and is that headache relevant in this present context of the diagnosis that you have made. Otherwise, there are so many reasons for headache which you need not bring in at that point of time when you are presenting your case. Okay, I hope you are getting me what I'm trying to tell. Then uh, finishing off, complaints of, if the patient has got facial palsy in the examination, then you go back in history again, take specific uh, complaint about any paresis or any facial asymmetry. If it is there, if the patient tells you that, and if it is associated with ear discharge, then commonly facial palsy if it is associated with ear discharge, will be in unsafe CSOM or aticoantral type of CSOM. And if it is associated with deafness, then we are looking towards a diagnosis of acoustic neuroma, which starts with the eighth nerve and then involves the seventh nerve also. So, okay, so this is a postgraduate question, but you can be asked a question in the viva that what are the causes of facial palsy associated with deafness, then the answer is acoustic neuroma. And then an intact tympanic membrane with no discharge and has a facial palsy, then the commonest causes the idiopathic lower motor neuron unilateral facial palsy, which is called as Bell's palsy. Okay, so these are the different viva questions which I have highlighted. You can be asked if you are presenting, and then you need to talk about facial examination and evaluation of the facial palsy, uh, rather the examination of the facial nerve, specifically if your diagnosis is coming out to be unsafe CSM. And there is no harm done if you have mentioned in your examination that I did a facial evaluation, uh, even if it is a case of safe CSM. Then if there are complications like diplopia, which is commonly seen in petrositis, which indicates Gredinigo syndrome, which is a triad of syndrome which is comprising of ear discharge or conductive hearing loss and the palsy of the abducent nerve leading to diplopia and a retroorbital pain, which is because of the involvement of the fifth cranial nerve, okay, which is the trigeminal nerve. So this is called as Gredinigo syndrome. So you can be asked what are the causes of diplopia and what is Gredinigo syndrome. It's a very important short note. So to conclude, so if you have, depending upon the diagnosis, the complaints like facial paralysis, diplopia, headache, fever, and these things you will ask if you have a patient of unsafe CSM. Even if the patient has not complained about it, you must go back in your history and put it in your negative history that patient did have a complaint of headache or did not complain of headache, because you are trying to rule out the issues. So again, go back into history once you've done the examination. So here I show you just the important chart, or rather about the flow chart, just to revise. So this is the important complaint box, which I call D. Van He Fee Do. Okay, so there are the 10 complaints: D for discharge, D for deafness, O for otalgia, T for tinnitus, V for vertigo, A for autophony, N for the nerve, that is the facial nerve, and HE for the headache, FE for the fever, DO for the diplopia. Okay, so D. Van He Fee Do, that is what we do in history taking of ear case. And here we go again in short: the discharge, we talk about the smell, consistency, the color, the stain, the quantity, whether it is active or inactive, intermittent correlation with upper respiratory tract infections. And going a little fast about the deafness, the onset, course, degree of hearing loss, relation to the discharge, and the association to vertigo or the noisy environment, and about the otalgia, what is the onset, the nature and the site of pain, and whether are we dealing with referred otalgia, the 5 T's that I told you, right? Then tinnitus, that's the other T, whether the subjective or objective, unilateral or bilateral, and the association with vertigo or deafness. Then the vertigo, you have to differentiate whether it is a central or a peripheral type based on the intensity and the duration, and you do the examination, look for the nystagmus, okay, and the association with ear discharge, the deafness, or the positional vertigo that you have to look into. Then A for the autophony, common causes are secretory otitis media and eustachian tube dysfunction. Then N for the nerve, that is the facial nerve. and the He is the headache, Fe is the fever, and D is the diplopia. So at the end of the day, uh, a good history will comprise of all the findings that are supported in the examination and are supporting your diagnosis ultimately. So once again, before I conclude, I repeat myself that whenever you are presenting your case, whatever case may be related to ear or nose, you must, after doing the examination and finding your diagnosis, must go back to history and add or subtract depending upon the points in favor of your diagnosis, which you add, and minus those points which are leading away from the diagnosis. So with that, I will conclude, and I hope that you find this presentation informative for you, and if you have any doubts, you can post me those questions and ask me. I'll be happy to answer, and thank you very much.